So I'd like to introduce all of you to our guest faculty today, Dr. Pradeep Johnson. Of course, he will put on his one slide, which is bio, very illustrious person. He's from St. John's Medical College. And over to you, Dr. Johnson.
Thanks a lot, Reena ma'am. I think it's really great of you. So can I start my session?
Yes, please. It's all
Sure.
yours.
Okay. Thanks a lot, ma'am. And I would like to thank Reena ma'am, Shruti, and Pavan sir. I think they are like my godparents. No, I think they were there to mold me, and no, it has really given me a lot of boost. There are a lot of good news. We are also setting up tobacco control program in St. John's. I think that's a good news which I wanted to share with Reena ma'am and Pavan sir and Shruti. In fact, WHO is also planning to support us. We have not yet got any confirmation, but slowly, once that comes, I thought I'll. But our institution has approved, and they are out for supporting us in all the ways. So I think all the credit goes to my mentors. I think Dr. Reena ma'am, Shruti, and Pavan sir. I think we thought that I wouldn't have been interested in tobacco at all. No, I always wanted to do some work in tobacco, but I got that opportunity to be trained under them. I was also trained like you, all of you sitting today evening and listening to this beautiful sessions. I think it's very important is to understand the concepts well. There are a lot of materials outside available, but if you don't understand the concepts, then it becomes very difficult to actually help your patient. I think the key of tobacco, not only tobacco, alcohol, or any other drugs, the key, what I got a gist of understanding what is a concept is actually, you should have something called as unconditional love. How you would love your children, or how would you, like if your child makes a mistake, will you keep on hitting the child? No. Initially, maybe you may try to counsel them. Initially, you may give them 2-3 chances to recover. So similarly, we have to treat our patients also like that. No, that is called as unconditional love. So that's what the core concept of the whole motivational interviewing edition 3 is about. Okay, when you get a chance to read about motivational interviewing, practice that, you will actually encounter that particular aspect. Okay, so with that note, I would like to start today's class. So I'm going to talk about biopsychosocial model of tobacco use disorders. Anybody, if you have any doubts, please stop me and ask me any questions if you have. That will be really great for me to answer you those questions. Don't hesitate to stop me, okay? Because understanding is very important. If you don't understand the concept, there's no point in doing this class, okay? So please stop me anytime. So today's learning objectives is about review of definition of tobacco use disorder and biopsychosocial model. We'll be dealing with each factors independently and describe the characteristics of nicotine that contribute to tobacco dependence and apply the background information for better treatment process. So very briefly about myself, I'm Associate Professor of Psychiatry and also part of Medical Ethics and Institutional Ethics Committee. And I'm also an editorial member of Journal of Addictive Diseases. Okay, currently in the last 2 years, I've won around 5 awards and around 40 publications so far and 8 book chapters. And I also written 1 book on mental state examination. Being a psychiatrist is very important to teach our students how to learn the basic facts of psychiatry. And also very important is currently I'm running a nurse-conducted brief intervention in alcohol use disorders in gastroenterology ward. But more so is we are initiating tobacco control program in our institute, PAN Institute, and also we're planning to do advocacy program, which will shortly be informing all the members. So this is a very beautiful picture which says how addictive tobacco can be. So whenever I think of quitting smoking, I need a cigarette to think. So it is that much addictive. Okay. So when we talk about biopsychosocial model, Okay, there are three aspects to it. The one is biological aspect, social aspects or environmental factors, and psychological factors. So basically, this has beautifully put it up. It is intertwined. That is, they are all not individually acting on us, but they are all acting together. Okay, that is a concept which you need to take home. So coming on to the biological factors, we'll talk in detail about that. So this particular chart will actually, or the figure will briefly tell you about an overview of how each factors play an important role. For example, there's a tobacco product is there. Because of environmental influences, a person starts smoking. There is nicotine in the body that acts on the receptors, cholinergic receptors, and later that causes neurotransmitter release. That leads to reinforcement, that is enhanced performance, mood modulation, lower body weight, reversal of withdrawal symptoms, and self-medication. So this is a vicious cycle. It again goes back to smoking behavior that causes increased smoking use, increased nicotine in the body, reduced tolerance, and this vicious cycle keeps continuing. So we'll come back to this in the end of this study or this talk also. So going on to the nicotine, genetics of nicotine. Okay, does everybody believe that genetics plays a major role? Is there anyone who feels no, it doesn't play a role? You can raise your hand or you can put it in the chat box. Does anybody feel genetics does not play a role at all? Anybody would like to voice their opinion?
Sir, I think it plays a role, but not a major role. This is my personal opinion.
Sure. Anybody else? See, this is a learning session. Please don't feel shy. You have to say your opinion. It's very important to contribute. No, that's why. Otherwise, there's no fun in discussing this. Anybody else?
Sir, I think it's on the metabolism majorly.
Okay.
Rest, I'm not sure regarding the other things.
Okay. You feel it depends on the metabolism of nicotine, and that contributes, isn't it, Sudeep?
Yeah, yes, sir. Yes.
Okay. Has anybody, can I ask you another question? Has anybody smoked here in this group? Has anybody attempted smoking in any form or used tobacco products?
No.
No, not at all. Not at all. Okay. Very surprising. Okay. I've experimented. When in my teenage days, I've tried it, but I don't know, because of my genes, none of my family members smoke actually. And I don't know whether it's the genes. I never got addicted to that at all, any point of time. Okay. Or I never felt that craving towards smoking. So it's very important to understand that genetics plays a major role. It is your genes, which actually determine, at least in alcoholism, it plays a 50%, almost 40 to 50% of genes contribute to your alcoholism. In nicotine also, it plays a stronger role. So there is a component of nicotine genes in nicotine addiction also. So it's very important to keep that in mind when you're discussing with your patients, or you're going to talk about that to your patients, because it makes a major role. Because we are going to discuss about the psychological aspects, how it's going to impact their children also. So I think it plays a vital role, is what you should keep in mind. Okay. So based on twin studies, that is monozygotic twins, they found that there is a high degree of heritability of cigarette smoking, almost 50%. So even in nicotine, it has played a very important role. And most prominent were genes within the alpha-5, alpha-3, beta-4 nicotinic cholinergic receptor gene complex on chromosome 15. Okay, please keep this in mind. And there are polymorphisms in a cluster on chromosome 15, okay, which encompasses the Na5, Na3, and NB4 genes. Okay, so coding for 3 subunits of the nicotinic acetylcholine receptor. So coming to say that genetics has a very profound effect on nicotine addiction. Now, we all know, I think already Reena ma'am was discussing about this, that dopamine is a key neurotransmitter in our brain, actually. So, for example, our basic needs like food, sex, or lot more other biological functions are actually mediated by dopamine. Okay, like movement, motivation, reward, dependence also is component of this particular neurochemical aspect. So it has shown that natural rewards elevate dopamine levels, like your food, sex, and nurturing. Okay, it stimulates dopamine neurotransmission, and the more it gets reinforced or hardwired, or what we call as reinforcement, no, the more it gets strengthened, the circuits in the brain also get strengthened, and the brain is very sensitive for dopamine. Okay, and you can see in this graph also how sex or food can make a significant impact on your neurochemicals. So the basic mechanism of controlled dopamine release and reuptake has been carefully shaped by evolution to reward normal activities critical for our survival. And I would say that dopamine had a major role to play in our evolution also as human beings. So I think you would have already seen this chart. I just wanted to reinforce that. I just wanted to say that this is the reward pathway. Okay, so this is the ventral tegmental area, which is magnified here, where your alpha 4 beta 2 receptors are there, and which is actually going on to the nucleus accumbens. Okay, as you can see. Okay, so this is called the reward pathway. Okay, so this gets reinforced when there is significant any kind of a substance use. Okay, so slowly initially, it gets triggered, and slowly the circuit is actually strengthened or hardwired, as we say. So nicotine and all the other drugs reward pathway are likely to be abused. So what happens, they hijack the reward pathway to make us think that we need it for survival. So we need only food, water, sex for survival. We don't need nicotine or alcohol for survival. But because of this hardwiring, slowly it gets hijacked into that kind of a thinking. Okay, and these effects can overcome, and tobacco users can be given hope based on this hypothesis. Okay, now coming to nicotine and the brain. So there is something called as neuro adaptation, which leads to tolerance. That is, it occurs when with repeated exposure to nicotine. If you keep on smoking or if you keep on using nicotine, the receptors becomes desensitized or unresponsive. And the brain compensates by increasing receptors and binding sites. And in fact, the brain chemistry is altered. Okay, if you keep on taking nicotine, what happens? It goes and blocks the receptors. So what happens? The receptors are blocked. So what happens? The brain slowly gets adapted to that, and it starts producing new receptors and craving for more nicotine in the brain. So what happens? So in the period of abstinence results in withdrawal symptoms. So that is why if suddenly one day you don't take nicotine, it causes withdrawal symptoms. So it can be sleep disturbance, it can cause anxiety, it can cause restlessness. These are the kind of symptoms you get in nicotine withdrawal. Okay, so nicotine, so end of abstinence, like you smoke a cigarette, again your nicotine starts binding to the receptors and it elevates craving and withdrawal symptoms. So that is how the whole nicotine is associated with the brain. So what actually, what contributes to dependence? Okay, I think you would have read the WHO criteria, the 6 criteria for dependence, but very important also is to remember that tolerance contributes to dependence. Okay, your body gets the side effects, your body keeps on absorbing this nicotine, but after some point of time, the body needs more nicotine, and that is where the lot of factors come into play. Okay, like how your body metabolizes nicotine also is very important. Okay, I may take one glass of alcohol. I may get fit with that. Okay. But for some people, they may need to drink 2 or 3 glasses of alcohol, or let's say pints of alcohol. Okay. Similarly, I may be happy or feel better with 1 cigarette or 2 cigarettes, but another person may need to smoke some 10 cigarettes to get that same effect. But ultimately, your smoking intake will gradually increase, or the tobacco use will gradually increase, because your body is slowly getting tolerated to that. Okay. So it again comes back to the question of genetics, environmental factors, modeling, pattern of use, duration, and amount of use. Now, so far, is it clear? Any doubts on biological factors before we go on to the other aspects, socio-cultural aspects? Please feel free to ask questions. Yeah, yes, ma'am. Go on. Yeah, please go on. Yes, somebody was about to ask a question. Please go on. Any doubt so far?
Sir, I had a doubt, sir. We
Yes.
were talking about genes. So these genes, are they environmentally modified, like epigenetics, or I wanted to know.
So I always use an example of loaded gun. Okay, will a loaded gun automatically shoot?
No.
Maybe very much advanced ones have, but a normal loaded gun, let's take a pistol. Will it suddenly shoot itself?
No, sir.
No. So what and all is required for, let's say you need to shoot something, let's say something you want to shoot. How will you do it?
So we need a motive,
trigger.
trigger.
You need a trigger. You just trigger will shoot a gun.
We need to
We
aim
need the
it.
bullet.
Bullet,
We need the
obviously.
bullet.
Without the bullet, it will be like a child's play, no? You'll be just tap, 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 it will be there. There's no actually gunpowder, nothing is there. Okay, so you need a bullet. You need a trigger. So what I'm saying is, the bullet is a gene. The trigger is the environmental event. That means certain people are programmed to get certain disorders. Another example, another analog which I always use is, do everybody in this world develop cancer? No.
No.
Isn't it? No. I mean, it's not that everybody in this world will develop cancer. No. Will everybody in this world develop diabetes?
No.
No. Again, coming back to the question, why only some people? Because of genetics. Genes produce proteins, and that proteins manifestation is us. Okay. If I have to be dark, if I have to be white, my hair has to be curled, I have to have a mustache. Everything, each and every aspect is determined by genes. Please remember that. So any changes in the genes can modify, or you may have increased propensity to develop certain disorders. So coming back to your question, environmental factors. So in the future generation, as you said, no, let's say a person is exposed to a certain toxin. Okay. In the future generation, there is a chance that that gene can get modified, and in the future generation that can start giving problems, or it can start giving some kind of a different kind of a protein synthesis. Okay. But for a person, that changes may not occur because it's already programmed. We are all programmed and sent into this world. We already have certain vulnerabilities. Okay. So does that answer my question?
Yes, sir.
Okay. Any other questions? You can use the chat box, or no, you can ask me anytime. Please stop me anytime and ask me a question. So let's go on to the socio-cultural factors. So community, environment, or even political influences that exist prior to individual choice, and that influence individual choice, are referred to as social determinants of health. Okay. Now, for example, you take the economic stability of a country. For example, now, you know what has happened to Sri Lanka? Okay, there's sudden financial crisis, the whole government is toppled. Okay, so that is the kind of economic instability we are talking about. Okay, or your neighborhood or your environment in which you're staying. What is the healthcare facilities there? Social kind of a standing, community kind of a context. Like in some communities, the smoking is banned. In that place, very rarely a person will smoke. So environment, education, economic stability, neighborhood or the environmental build, healthcare system, all contribute or are also called as social determinants of health. Now, talking about health inequities, okay, there are two important aspects which you need to think about. Okay, what is the difference between inequities and inequality? We'll come to that. So inequities is caused by unfair social policies and practices due to lack of health promotion, resources, or increased exposure to risk factors. For example, if you take India, many of them, or I would say, we don't have a government policy on insurance, isn't it? So many people, even now, they struggle to actually face or go and take health treatments. No, even though government has made efforts, to provide primary care support, staff, availability of medication, not many people actually go and take it very easily, except for maybe tuberculosis, HIV, on other major disorders. But let's for example, mental health, not many people are forthcoming and willing to take treatment. So inequities actually play a major role. No matter your government supplies medicines, provides medicines freely or at a cost-effective rate, it is people's perception and how they tackle with those problems and go and take help is again a social problem. So health inequity, when the underlying cause of tobacco-related differences in use, health consequences from or access to treatment is socially produced or avoidable. So this is a very classical diagram which we use to explain health equality versus health equity. So health inequality, okay, when you consider equality, you can actually miss out on some people. You look at the disability, for example. Okay, when you think about equity, you are giving chances or the support to the discriminant or the worst person or the worst disabled in that. So talking about health equity, more health equity, decrease smoking rates among underserved population. Okay, so that is what we are talking about. Now, social demographic factors. I think age, gender, income, education, everything plays a vital role in determining in terms of whether I should smoke or whether I should maintain my smoke or whether I'm going to consume tobacco for a longer period of time. Okay, so of all the factors, education and household income are among the most important aspects. Studies have found that education and income levels rise, smoking rates actually fall. So the more you're educated, the more income levels are there, the lesser chances of you having smoking rates. And mind you, this is true across all ethnic cultural groups. And this relationship has been consistent despite lower smoking prevalence rates over time. Over time, if you see that in all the countries and globally, the rates of smoking is coming down. But this equation of education and income levels rise, smoking rates fall down is very, very much found in all culture and ethnic groups actually. Social influence. I think you all will agree with me that like when you're persuaded, okay, or when you're some group of people imitated. For example, let's take Rajnikant or Amitabh Bachchan. Earlier in all the films, they used to role model, and people used to learn from that, and they think it is a status. Like, I would also like to smoke. Like, they want to try it or experiment it and feel like, no, I'm the boss if I smoke. Okay, so role modeling plays a very important role. Role modeling can be from a film character. Role modeling can be the family member, an uncle or a father figure who actually smokes, okay, in the environment, which can actually motivate people to smoke. Or let's say your teacher is smoking, you also have a tendency to smoke, okay? Or your colleagues are smoking, you also will have a tendency to smoke. Slowly you will get into that loop, okay, where you're also encouraged to smoke. Are the moment you say no, I don't want to smoke, you're left alone out of that group, okay? So social cognitions or social kind of a cohesiveness, okay, where you need to smoke is a very, again, an important aspect. And influencing beliefs also. And many people feel that, yeah, if I smoke in public or if I smoke, I am more, have more self-esteem compared to a person who doesn't smoke. They'll say he's a darpoke, he doesn't, he can't smoke in a social situation, or he can't smoke with friends. Okay. Attitudes. No, what kind of attitudes I have towards smoking. That also can determine, no, whether I need to continue smoking or I have to smoke. Okay. Norm setting. Okay. Norm is nothing but a particular aspect which a society follows or a culture follows. Certain cultures, they all sit and smoke together. In some culture, it is a ban. It is taboo. You cannot smoke. Okay. You need to maintain the dignity. Okay. So those aspects actually make a very important role that is called social influence. So it directly or indirectly influences a person on continuing smoking or maintaining dependence. Role of peers and even social networks. We all know that peers have a significant influence on smoking. Peers can be in the form of friendships, romantic relationships, and social networks. Okay, and the biggest impact during adolescence is peers, and they found that in young adolescent, 99% of people who smoke start before the age of 26. 88% of people who smoke start before the age of 18. So that young, I know of children who smoke even at 13, 14. No, at that young age, they start smoking. And also, girls are more influenced by than boys, influenced by their peer group compared to boys. So remember that it's not only boys, but girls also get influenced very easily. Parental smoking, very important. Okay. It definitely, parents and older siblings also have a significant influence on smoking. So these are the studies which they have found that parental smoking status is associated with 2 times the risk of the adolescents smoking themselves. Fortunately, parental quitting is also associated with the child who has become a smoker to quit smoking. So it has a positive effect and also negative effect. So that needs to be kept in mind. Okay. So you can see in that graph also that no parent smoking, never smoker. One parent smoking, there is significant increase in the percentage. Compared to 2 parents smoking, there are very higher levels of them to be in the current smoker group. Again, talking about environmental factors, co-workers, friends, family who smoke increase the likelihood of smoking and decrease the chances of quitting. Okay. Social non-acceptability of smoking. So even though in India, many places it's banned, but still we find that in some pockets places, people do smoke, still continue to smoke, especially in workplace, in work atmosphere. It is like permissible, it's allowed, like the people are continue to smoke there, and it reinforces other people who even want to quit. So they're helpless and they start smoking. Presence of a non-smoker or a smoker in your family as a partner, that also influences. Access to cigarettes and smoking environments, like household smoking bans related to smoking cessation. So many times in many families it is banned, they don't allow you to smoke. So definitely there is no chance of you smoking. Workplace bans, like many workplaces like hospitals, certain offices, it's very clear that you cannot smoke. like cinema theaters. No, it is all banned now. No, you cannot smoke. So these kind of bans actually help in people from avoiding or quitting smoking very well. And role of built environment. Okay, we know that when you go to certain hotels, they say very clearly, sir, sorry, this place you cannot smoke. It is smoke-free area, so you cannot smoke. So it is banned. So these kind of social or environmental influences can play a major role in quitting or maintaining tobacco dependence. So build environment also, no? Absence of smoke-free regulations, tobacco marketing, tobacco retailers, okay, they also find a very important role. Like many times, many places, they ban smoking. You cannot sell tobacco in that office or in that environment. Okay, so these are regulations. It depends on the regulations of a country or a state or even local offices also. That plays a major role. Okay, now we talked about environmental factors, but what about cultures? Okay, subpopulations, for example, tribal, rural populations, some groups do smoke. Like if you go to North India, places where the environment is very cold, I mean, it is a general practice to smoke actually, to keep their body warm. Whereas if you come to South, you may not find that kind of practice. No, so it depends on the climate. It depends on the environment. College students, no, it is, as I told you, it's an attitude for them. No, they need to show that they are free. They are not bound by any rules and regulations. So the culture in that plays a major role. Chronically ill or mobility impaired. Okay, so many people who are even have psychiatric disorders. No, they are addicted to smoking also. Military, no, some have strict rules, some smoking is allowed, alcohol is allowed. So it depends on what kind of restrictions they have. Now there can be ethnic differences also. There's something called acculturation. That is, it affects both tobacco smoking and quitting behaviors. That is, years living in a given location, immigrant status. For example, in your place, you may be smoking. The moment you go to a new place where smoking is banned, you have to slowly get adjusted to that. So obviously, you'll be stopped. You will be prevented from smoking. Language preferences, ethnic subpopulations, all of them make a significant impact on your smoking. We talked about this ethnic differences, like in terms of smoking. But what about quitting? For unknown reason, there are ethnic differences in quit attempts, quit success rates, use of medication for smoking cessation, and receipt of physician advice to quit smoking. So as a clinician, it is important to know these aspects in your local area or where you're practicing. Okay, what kind of influence the ethnic as an effect on your patient. So you need to study your area before even you prescribe quit methods or even prescribe any medications, or understanding that local milieu is very important, is what I'm trying to say. Okay, again, social influences also, even in ethnic differences, there can be social influences. Like, for example, perception of cigarettes and nicotine dependence and role of tobacco use in cultures. Like in Indian cultures may associate tobacco with medicinal or religious function. In certain groups of people, tobacco smoking is considered as medicinal. Okay, for example, in South India, you are given pan, okay, with betel nuts and sometimes tobacco. Okay, it is a tradition in marriages after their wedding, or after you have a grand lunch, you are given pan and sometimes stuffed with tobacco. Okay, or in Chinese groups, they gift tobacco. Okay, and also social marketing influences also can have a significant improvement. So there may be a target of intense industry marketing. No, there may be targets that certain industries have to sell so much of products. Okay, there may be influence from a lot of companies on that. So that also can make a significant influence. So the take-home message is know your community, and the role smoking plays in their lives. That is very important, I also feel. Okay, so far, any doubts before we go on to psychological factors? Anybody, any doubts or any thoughts came up when we were discussing about community settings?
No, sir.
Okay, so we'll carry on with the psychological factors. Very interesting. Okay, so psychological factors. Okay, they are also important component of biopsychosocial model and can influence smoking initiation, maintenance, and quitting behaviors also. Okay, so there are various factors of psychology. For example, thinking, the way we think, the attitude, personality, social stresses, which we talked about earlier, our emotions. Okay, emotions play a vital role in smoking. Please remember that. The moment a person is depressed, the moment a person is happy, they feel like smoking. Okay, psychiatric comorbidities also has an influence on tobacco use and maintenance. Okay, and psychological factors are often one of the reasons that makes breaking nicotine dependence so very difficult. Okay, so every aspect like biological, your environmental or cultural and psychological factors are almost intertwined, and that actually keeps on your smoking go. So what are the tobacco, we all know it is a psychoactive substance, and it is one of the commonest used drug throughout the world. Okay, legal drug which is used throughout the world or globally. Okay, so what are the effects of tobacco which causes or what are the psychological effects we can see? It definitely causes stimulation. Okay, what does alcohol cause? Can anybody tell me what does alcohol cause? What is the effect of alcohol on the brain?
Suppression, sir.
Excellent. Okay, or what we call depression. It depresses all the brain functions, whereas tobacco stimulates and it causes arousal. Okay, that is why you'll see students taking it, or people who want to concentrate, who feel that it is a paradoxical excitement or paradoxical arousal. Initially, it causes stimulation, but later on, it causes damage to your brain. People say it relaxes. I don't know how it relaxes. It causes actually, it is a psychological. Actually, if you see Freud and all, they used to actually use pipe to smoking. Okay, do you know why Freud or there is a concept something called as oral fixation. Okay, if a person keeps on using the mouth too much, okay, they have a tendency to develop addictions. Okay, anything oral, like if you keep on using cigarettes, okay, it is called oral fixation psychologically. These concepts have been proposed by Freud. Okay, so if you tend to use your oral cavity too much, then they have a tendency to develop. So it is unconscious. I mean, you don't have to worry about the concepts properly. This is an unconscious state. There's something when Freud talked about conscious, subconscious. So basically, I'm talking about oral fixation during the developmental phase. Okay, so if there is any fixation in oral aspect or a oral stage, what we call, then they develop the drug abuse. Okay, so they say it regulates the mood. It is an appetite suppression, definitely. It actually helps you in your weight management, sometimes pain, and it actually reduces anxiety. And that is why people tend to use it in social situations. They feel more confident when they use smoking, and also helps in facilitation. People say that it enhances memory, it enhances attention, and also it increases speed of processing. But all these effects are very transient and only in the initial aspects it causes. So improvements may be result of relief from actually the withdrawal symptoms. It is not that it actually causes the original benefits, but it actually is because you get hooked onto it. If you stop, you become dull and if you smoke, you actually feel better. So this is the logic behind the psychoactive aspects of this tobacco use. Triggers pleasurable feelings and smoking. So basically, this combination is really a bad combination. Okay, so there are smoking triggers. Like I see my friend smoking, he gives me a free. He just shares his smoking with me, or then I have a tendency to smoke. Okay, that triggers a lot of pleasurable memories, what we call as positive reinforcement. You would have read about Pavlov's experiment. The moment you give food to you keep a food, there is saliva production in the dog. Okay, and a bell is rung. Next time you don't keep the food, but you just ring the bell, you start salivating. Okay, so that is called as a simple experiment which Ivan Pavlov had developed, that shows that we also subconsciously have this kind of positive reinforcements. So the moment you smoke, there's a smoking trigger. You think about the past pleasurable activities which you had with your friends or relatives or at home. Okay, so pleasurable moments, again, you feel that if you smoke, you will get back the pleasurable moments. You start craving for that, and then go into the loop of smoking or relapse. So triggers, pleasurable feelings, and smoking are again related to each other. Thoughts, emotions affect the behavior. Okay, so let's say I'm very much tensed, I'm working on some project, I'm not able to continue with that. I smoke, I feel a relaxation that gets hooked onto it, and then every time I'm stressed, I may want to take a smoking. That gives better. I feel better with that. So again, it is a vicious cycle. So situation which causes thoughts, emotions, and behavior. An example is here: work. I'm stressed. I feel sad. I feel like smoking. That again causes stress. Again sad. So it's a vicious cycle. So we have to break the cycle when we are looking into certain behaviors which the patients have. Attitudes, beliefs also influence our tobacco use. So perceptions of tobacco, what do people believe? Like I showed you a photograph of Rajinikanth smoking. So people believe that is normal. Okay, it's normal to smoke. Okay, it's a norm. If an actor can smoke, no, I also would like to smoke. I would also like to get fame. I also would like to get. I also would like to be accepted in a group of people who are smoking. Intention or motivations. Okay, refusal self-efficacy. No, I may not be very assertive. Friends, the moment friends give me, I cannot say no to them. I'm not assertive. So that can again influence my smoking intake. Quitting self-efficacy. If I'm not very strong, if I'm not assertive, I can't quit. The moment I see someone smoking or my friend is giving a smoke to me, I get easily influenced. Risk perception. Okay, I perceive vulnerability, perceived benefits. So many times we feel, yeah, if I don't smoke, my friends will go away from me. They are my only friends I have. Stresses are also linked to tobacco use. For example, childhood abuse, verbal, physical, or even sexual abuse, socioeconomic stress, poverty, non-specific stress, sometimes daily stressors, all contribute to tobacco use. Okay, I think we have come to the end of the class. I'll just summarize some important factors which you need to take home. Okay, so summarizing the biological factors. Biological factors contribute to the establishment and maintenance of dependence. Genetics play a vital role, almost 50% or even more than that. Nicotine per se affects the receptors, which strengthens the reward pathway, which affects your memories and behaviors, which strengthens that in terms of neurotransmitters. We talked about tobacco. Synaptic connections are strengthened. Smoking delivers nicotine via lungs to brain in 7 to 10 seconds. Nicotine produces other physiological effects also, which you definitely will know about. Social factors. I discussed about role modeling, parent smoking, peer smoking, home environments, how stringent they have to be to prevent smoking, cultural factors, ethnic factors or ethnic groups which actually contribute to smoking. Psychological factors, attitude, personality, It goes on to contribute to the initiation and maintenance of smoking, perceived vulnerabilities, attitudes about smoking in an environment, all are linked to psychological factors. Now, coming back to the original figure which I've shown you, tobacco product, environmental influence, genetic aspects contribute to the age, sex, genetic predisposition, psychiatric disorders, substance use contribute to your smoking behavior. How much smoking goes into your body, it is metabolized, how many receptors are blocked, neurotransmitters release, reinforcement of that leading to tolerance, reduced tolerance, and then that vicious cycle of becoming addicted, and maintenance of that addiction is the important aspect of this talk. Okay, so I hope I was able to convey some important aspects of the biopsychosocial model. I think it is open for discussion now. Any doubts, clarification, you can please ask me.
Thank you, Dr. Johnson. That was an amazing presentation and very
Thanks a
well
lot.
done.
Thanks
And
a lot.
I request all of you to please ask questions and take advantage of the fact that we have Dr. Pradeep Johnson with us. Till we understand our patient, we are not going to be able to go to the next step of the cessation.
Correct.
Ma'am, I have a question for sir, ma'am.
Please.
Sir, you said something about that oral this thing. I mean, I did not get that, sir. That
Yeah.
fruit
So don't
thing?
worry. It is more a psychological theory. Okay. Freud came up with something called as conscious and unconscious states of mind. Okay. We all develop from childhood. Okay. So when we develop from childhood, there are various stages of development which should occur. So it is called oral stage, anal stage. So like that, there are different stages. If you go back, if you just type Freud stages of, it's called psychosexual development. Okay. Freud believed that during that time, Freud believed that we all develop through these phases. Okay. If the development does not occur at a specific stage, you develop certain disorders. So for example, if you get stuck at or fixated at oral stage, according to Freud, okay, you have a higher tendency to become dependent to some substance. You can get addicted to tobacco. You can get addicted to maybe alcohol. So that's why it's called oral phase. Okay, that's why the traditional person smoking is a very traditional aspect of they're using their oral cavity frequently, or they have a tendency to eat more.
Okay.
So it is a psychological concept that this is based on the psychosexual development which Freud proposed that time. Okay, so it is one of the theories which it is based on psychology.
Thank you, sir.
Sir, I'd like to ask something.
Please.
Good evening, sir.
Good evening, ma'am.
First of all, thank you, sir. It's such a huge topic, and you've explained it to us in such a lucid manner. I wanted to ask you, sir, as a psychiatrist, what is your opinion? Are we, because it's such a play of multiple factors, this tobacco addiction, you think we are capable of handling a tobacco addict, or our role is just a supportive role in guiding and motivating the patient? Would you want a patient to be referred to you, especially now that we have DM, addiction, psychiatry? What is your perspective as a psychiatrist? I'd like to know.
Can I ask you one question? Why have you taken up this course?
That's what, sir. I am intrigued. I want to contribute. That's why I've taken up this course. But because it is a play of such multiple factors, I want to know if I would be adept at handling a tobacco addict.
That is the basic funda of this course. Okay. This course is actually empowering you. That is why these classes are taken, to make you understand how a person can be helped in different ways. You don't have to be even a doctor. Actually, Pawan sir will agree with me. Even a lay person can
Absolutely.
actually do this tobacco cessation. You don't have to be an expert. You don't have to be a doctor actually. A lay person can be trained to deliver brief intervention and he can just do miracles. So if a lay person can do, you as a doctor can do a lot more thing. Why? Because they come to you for some help. See, what we call as opportunistic screening, what we call. Every moment you should ask a patient, do you smoke? In the end of your history taking. Just one question, do you smoke? That's all. It will open up a Pandora's box. Okay. But what I'm saying, don't feel low about yourself. Oh, I'm not a psychiatrist. I may not be able to treat. No, you can make a difference. You can definitely make a difference. No matter what kind of background you're coming from, you still can make a difference. Yes, there can be challenging situations. There can be sometimes very difficult cases. You may try, you have to try 2-3 times, it's not quitting or something is maintaining them. Definitely you can refer them to a higher center or a little expert. But baseline, you can actually do miracle. And that is the funda of this whole course actually. And that is what you're being trained for. Okay.
Thank you, Dr. Johnson. It has been a wonderful presentation as usual.
Thank you, sir. Thank you very much, sir.
I enjoy listening to your presentation every time you give.
Thank you, sir.
Learn something new always.
Sure.
And just for Garima, just to put it here, Garima, the initially when this tobacco cessation was started, it was supposed to be an habit, an addiction and habit. And then it was supposed to be like to be treated by a psychiatrist alone. It was the domain of the psychiatrist, right? Somehow, maybe because of my intervention, maybe because of the way we have made the whole course, maybe the way I started working on that, because I was not a psychiatrist. I was not a psychiatrist when I started this. And this is how it all boiled down, that we have to make it simple. Because you see, let me put it this way. Like oral cancer cannot be just the domain of a oncosurgeon. Oral cancer is a public problem. It is a public health problem, right? So it has to go down to the domain of the oral specialists. It has to go to the ENT. So everyone needs to be trained for that, right? Similarly, the tobacco, till date, very few people have been trained. And so, because no one was trained, so it was because psychiatrists used to do a little more because it was a habit. So they started getting, it became their domain. But now slowly it is slipping out of that domain, because this is a general problem, a public problem. Every person, every doctor has to be trained. Every doctor needs to know what is to be done for a tobacco cessation. If there is a hypertension, we know that we need to give amlodipine. If there is a diabetes, I know that I need to give insulin. That doesn't mean that I may prescribe insulin, but at least I know that I need to give insulin, and I may send it to an endocrinologist if it is required. But many doctors do treat diabetes as well, because I used to treat diabetes myself. I used to treat hypertension myself till I became a specialist and I started working on cancer alone, right? So Garima, let me put it, tobacco is a public health problem. Everyone, whether it is a pulmonologist, it is a cardiologist, it is a dental surgeon, it is a ENT, it is a gynecologist, it is a orthopedic surgeon, they should know the basics of tobacco cessation. This is the major problem. 70% of the patients who go to the hospital, 70% of the patients have tobacco related disease. So they need to be asked, they need to be treated. And Garima, after this course, Certified Tobacco Cessation Specialist course, you would see that we have got a lot of faculty and we are doing hand holding, right? Don't be afraid. When we did our internship, we went and asked our senior what are the medicines we need to write, right? We made a five medicines and we used to prescribe these 5 medicines to everyone. Isn't it true? Right? Similarly, this is how it will start. And once you become smarter and smarter, and once you start addressing the situations with the patient, you will become better. And then you will be the best, right? So that is how it is now that I have been working in this for such a long time. I am not an oncologist. I am not a psychiatrist. I am not but I made this thing because I put in a lot of efforts for that. So similarly, Garima, and for that matter, everyone, whether it is whoever it is, whatever subject you are specialist in, you will be able to treat tobacco cessation. It's not a, and we have simplified it. We have simplified it amply, right? By the end of it, today actually we are not giving the app. The app, when we will give you the app, maybe in the next class we'll start with the app, or maybe we'll have a full one session of the app, when you will know how to handle one step each time. See, right now you're learning the theory, we'll learn the practical also, how to handle this. So that's what it is. And I always have Dr. Johnson as friend, who always comes in and he helps in training. And he's one of the best in psychiatrist we can see in India, who has got a lot of very, very stable and works very well with the general population. So
Okay, thank you very much, sir.